Labor and Delivery Part 3. This is a labor and birth guide. I'm going to let you go over this at your own time, but it will talk you through each one of the stages and phases of labor, what to expect, what mom might feel, and what her coach can do. A different diagram of stages of labor. What happens during the labor process as far as station. Station is going to be where the fetus is in the pelvis. It's a way of measuring. We measure it by looking at the spines of the pelvis. And just a different diagram as to fetal station. So the fourth stage of labor is considered to be the actual recovery process. It's the first 2 hours following delivery. Usually mom is given Pitocin IM or IV. We encourage breastfeeding as soon as possible if mom's going to breastfeed. We repair the perineum, or the physician does, and apply an ice pack as necessary. Do not encourage mom to get out of bed unless staff is with her the first time. We begin to assess her vital signs, and this is very similar to what is done post-operatively. We assess the fundus. We're palpating for firmness and position. If the fundus, if the uterus gets boggy or soft, then mom is more apt to hemorrhage. So if she has heavy lochia, which is the vaginal bleeding following a delivery, it also has tissue within it, excuse me, then we are going to massage the uterus first thing. The lochia, make sure that you Keiko the drainage. Moderately heavy with potential clots is pretty normal for the first couple of hours after delivery. Lochia is defined as rubra, which is going to be bright red for 3 to 4 days, but it begins to decrease in amount by the second day. Serosa is going to be pink or brown, and again, lesser amount, and this can last up to 10 to 22 or 27 days. And alba, which is white to yellow, and this is going to be 10 to 14 days that we usually begin to see this. The perineum is frequently swollen, but we also want to make sure that it is intact, and we want to monitor swelling. We monitor for bladder distension and making sure that mom can urinate. But before we start talking about how to deal with mom following delivery, let's talk about getting her ready for delivery. Make sure that you are maintaining all of these things. If there is an emergency delivery, in other words, mom has waited too long to get to the hospital, or labor has progressed more rapidly than anticipated, or the physician is tied up by the train and can't get across the tracks in time to get there for the delivery, the nurses have to step in and do this. And it's really not as difficult as it sounds, and it is rather exciting. You never stop the client from pushing if she has the urge, but we don't encourage it if the physician is not present. But you never hold the fetus back from delivering. If you have the opportunity and the time, you need to cleanse the perineum and put on sterile gloves if at all possible. Support the fetal head and the body as it emerges. You never pull, twist, or turn the fetus. As the head delivers, you will suction the mouth, then the nose, if possible. Sometimes you don't have time to do that. You feel around the fetal neck for the cord. If you do feel a cord, you attempt to slip it over the baby's head. but the client should not be pushing at this time if at all possible, because it will just tighten that cord. Once the fetus is delivered, you place the newborn on mom's abdomen and you cover the baby with a blanket or a towel. You dry and stimulate that baby to cry, and always encourage mom to begin breastfeeding as soon as possible. Breastfeeding also encourages the release of oxytocin, and this can certainly help if mom is bleeding heavily following delivery. You're going to doubly clamp the cord and then cut it. And even though the physician isn't there, you never take away the opportunity for the significant other to cut the cord if that's what they desire and if they are available. After delivery of the baby, of course, you're going to be doing some vital signs on the baby, etc., monitoring mom, monitoring the baby. But you're also going to be observing the placenta for signs of detachment. As the placenta begins to detach, the cord is going to lengthen, bleeding will get heavier, and mom may experience some cramping. If at all possible, you need to obtain some cord blood while waiting for detachment, and you can do that by releasing the clamp on the mom's side of the cord and then reclamping it. Never ever pull on the cord itself. Following detachment, the placenta is placed in a container so mom can or not mom, but so the physician and or the nurses can examine it to make sure it's complete and intact. After detachment and delivery of the placenta, then we will massage the fundus to determine its firmness. If it is boggy massage, usually the uterus will firm back up with massage. If the physician has made it and you are assisting in delivery, then these are some of the tasks and chores that you will be responsible for. You also need to direct the significant other as to support techniques. They get into this situation and they forget everything they learned in childbirth class or anything that they have done in the past, etc. And sometimes they just need a gentle reminder. You also encourage pushing when the client feels the urge to push. This is called laboring down. In other words, back when I first started obstetrical nursing, as soon as mother was dilated to a 10, irregardless of the station, in other words, the descent of the fetal head in the pelvis, we started pushing. And it didn't matter if mom was ready to push or not. Laboring down allows the body to naturally push the fetus through the birth canal. It saves energy on mom's part, and it also saves stress on the baby's part. It is a much better method of delivery than encouraging pushing as soon as they reach that magic 10. It also decreases the need for episiotomies because the vaginal tissues, perineal tissues, are allowed to stretch much more naturally and slowly than they are if we are forcing that baby to come through. And we do not encourage the mother to hold her breath and push during the pushing process. We encourage her to push physiologically, which is the body's natural pushing method. This is a diagram of the two different types of episiotomies and the directions they can take. Complications of labor can be ineffective contractions. They can be either weak, infrequent, or brief, short duration, and these are hypotonic, or they can be hypertonic, where they're very painful, but they're ineffective. They're uncoordinated, they're irregular, they're short, and the intensity is just not appropriate. An abnormal labor length with a prolonged labor where we have minimal cervical dilatation, or the fetus just does not descend into the pelvis the way it's supposed to. A precipitate labor is going to be a birth that occurs within 3 hours of the onset of labor. Intense contractions usually begin rather abruptly instead of gradually. They also requires oxygenation to be promoted, so baby is certain to get appropriate oxygen. Cervical dilatation should proceed a minimum of 1.2 centimeters per hour in the nullipara and 1.5 centimeters in the parous woman. The fetus will descend a minimum of 1 centimeter an hour in the nullipara and 2 centimeters an hour in the multiparous. Prolonged labors, this does not happen. With prolonged labors, we see maternal or neonatal infection, maternal exhaustion, a high level of anxiety and fear, and it can be because of the fetal position and or size. A malposition is going to be any position other than the face down, head down position. So baby may be face up, it may be breech, it may be transverse. Shoulder dystocia is where the shoulders are too large for the pelvic outlet, and this requires pelvic pressure to help that baby's shoulders slip under the symphysis pubis. We can put the knees to the chest to provide a little bit more room in the pelvis for that fetus to deliver. And as a last resort, the physician may intentionally fracture the fetal clavicle to allow that baby to deliver. And premature rupture of membranes, again, increases the risk of infection. Various malpositions that we often see the babies deliver in. This is how we apply the suprapubic pressure to help that fetal shoulder deliver. This diagram shows where we expect to find the fundus at different days after delivery. We describe this as being at the umbilicus, 2 or 3 finger breadths below, 1 finger breadth below, or above the umbilicus, etc. There's two different types of incisions that we see with cesarean sections. We have the vertical, the up and down, or it's also called the phalansteal. And we also have the horizontal, or the low transverse incision. Indications for a C-section would be shoulder dystocia, a cephalopelvic disproportion, hypertension, maternal diseases, active genital herpes, previous uterine surgeries, persistent non-reassuring fetal heart rate patterns, a prolapsed umbilical cord, fetal malpresentation, hemorrhagic conditions. Contraindications would be a maternal coagulation defect. Risks for C-section, of course, are going to be hemorrhage, infection, or an anesthesia risk. C-sections are usually done with epidural analgesia, and the client's awake for the delivery of her baby. A Foley catheter is placed, and it's usually removed within 24 hours. The support person is allowed to remain at the client's side, and 1 obstetrical or neonatal nurse per infant is in the C-section room to take care of the baby after delivery, and a second person, and often this might be a respiratory therapist. Mom is often allowed to see the newborn while she's still in the operating room, and postoperatively is the same day as any surgery, except we're also monitoring the lochia and the fundus. This shows you the 2 different types of C-section incisions. A VBAC is a vaginal birth after a cesarean. A lot of women who end up with an unexpected cesarean section would like the opportunity to attempt to deliver vaginally with a subsequent birth. Contraindications to this can be a previous classic cesarean incision. In other words, it goes up and down instead of across. Other uterine surgery, a previous uterine rupture, or the unavailability to perform an emergency cesarean section. There's one major risk to a VBAC, and that would be uterine rupture, because contractions put stress on the uterus incision. There's more stress placed on the incision if it's the classical incision versus the low horizontal. In order to perform a VBAC, the woman has to have that previous low transverse incision, no other uterine surgeries or uterine rupture, because the risk of a second rupture will be increased, and again, the availability to perform that emergency C-section. There should be one fetus, and it should be head down. The risk of uterine rupture is present for all women, but those who have had a VBAC, the chances increase with aggressive induction and augmentation. But that happens only in a VBAC, the risk of uterine rupture is less than 1%. A VBAC information should be provided to the mother prenatally so she can decide and make an informed decision regarding the type of delivery she's going to have. Explain all the advantages of a VBAC as well as the risk associated with a VBAC, such as that uterine rupture. And have the operative team ready. They need to be available within minutes, usually a 30-minute time frame or less, depending on the size of the facility. Spontaneous onset of labor is ideal because there's a greater risk of rupture with that induction. But if induction is done, close monitoring of the oxytocin is required. And we do not recommend the use of prostaglandins for a woman who is having a VBAC.